Hello everyone, welcome back to another podcast. I am Dr. Ankita, MSL for the East Zone in Glenmark Oncology. Today, the title of our podcast will be Blood Cancer, Understanding What We Don't See. So, unlike other cancers, blood cancer doesn't show up as a lump or something visible. And this makes it even more frightening and confusing. So today, we're going to break it down in a very simple and clear manner, understanding what it is, how it presents, and what the patients really need to know. And to guide us through this very important discussion, I'm very glad to welcome Dr. Asif Iqbal, Associate Professor of Adult Hematology, Department of Medical Oncology, Dr. Borooah Cancer Institute, Guwahati. Thank you so much, sir, for joining us.
Thank you.
So, sir, starting with something very basic. So, when we say blood cancer, sir, what exactly are we referring to?
Okay, so blood cancer refers to the cancers arising from blood, bone marrow or lymphatic systems. The origin of the cancers can be either white blood cells circulating in your blood, or it can be bone marrow. So there are different cells in the bone marrow. It can be lymphatic system, which usually presents as lymphoma. Together, they are referred to as blood cancers because unlike solid tumors, they are not localized to a place. So they are systemic, much more like humoral. Okay, and from the very onset, they go to all the places.
Right, sir.
So there is no concept of like stage 1 or 4 in blood cancers, and because they are humoral, we refer collectively all the cancers of the blood system as blood cancer.
Got it, so thank you so much. So another thing that came in my mind was blood cancer, unlike other cancers, as I said, doesn't show up as a lump. So how do we identify?
So unlike most other solid tumors, for example, a breast or lung mass, or if somebody has a stomach cancer, which usually has a lump, right, which is usually a mass, localized to the origin of the organ. Blood cancer usually have indirect symptoms. So one of the symptoms will be deficiencies of hematopoietic system. Now, since blood cancer originates in the bone marrow, obviously your natural bone marrow cells like red blood cell or white blood cell or platelets will be reduced. So you will have symptoms to that. So you will have easy fatigability, you have more bleeding tendencies, you have frequent infections, okay? And those symptoms are pertaining to the deficiencies of the hemoglobin, platelet or WBCs. So that is one part of the symptoms. Another part of the symptoms is just like you said, lump. Yes, in blood cancer also there may be lumps, but those lumps are called nodal enlargement. So you can have nodal enlargements in your neck, in your armpit, in your groin, in any other parts of the body. But unlike solid tumors, they are not the origin of the disease. Let's say somebody has a stomach cancer, the lump will be placed right here. Somebody has a breast cancer, it will be palpated on the chest. But in blood cancers, there will be lumps in multiple areas of the body, and they will not be the origin of the tumors. So there are two types of symptoms, as I said. One is the hematopoietic symptoms, and another symptom is because of lymphadenopathy.
Thank you. So that's a lot of clarity. So since you talked about symptoms, so fatigue and weakness are very common symptoms in any normal person as well. So how do we know if it is something serious, sir?
When it is out of usual, okay, you will have fatigability. A normal person will have fatigability during viral infection also, but it will be short term. It will recover by itself. Sometimes some other diseases like hypothyroidism or liver disease like chronic kidney disease can have fatigability, but those fatigability are very gradually progressive over a long period of time. In blood cancers, the fatigability is progressive, but it is of a short duration of time. So you can expect a person of blood cancers or leukemia to have fatigability, but it's usually less than a month old, and they're progressive. So every day the fatigue will increase. And when something happens which is out of ordinary, out of the usual, and you do not have viral fever, you do not have these things. Whenever something happens out of ordinary, you have to suspect blood malignancy. It's not very uncommon. People think it's uncommon, it's not uncommon. You have to get a very safe and simple test done, that is complete blood count. You do a complete blood count, it gives you lot of information, even if your hematopoietic system is, your bone marrow is not involved. Even if it is not involved, it will give you information. If the bone marrow is involved, it will obviously give you the diagnosis itself. The CBC is so informative. So I suggest that whenever you have fatigability, even if you think that you do not have blood cancer, okay, fatigability is there, doing a simple test like CBC solves a lot of problem.
Okay, thank you so much. I think that's something most of our viewers can relate to.
Yes, not blood RD, complete blood count. CBC, complete blood count. Every diagnostic center does it. And you can do that. If you are feeling unwell, you can do that. If you're feeling unwell frequently, you can do that every month. There's no problem. It doesn't have so many CBCs done. It's cheap also. CBC cost, I think in private hospital, CBC charge around 500 rupees. It's a very simple and cheap test to do, but it gives you a whole lot of information.
Absolutely, sir. Thank you so much, sir, for that. So, sir, now let's talk about the types of blood cancer. So, we often hear these terms like leukemia, lymphoma, myeloma. So, for our viewers, if you please could explain how do these terms differ from each other?
These are terms for the layman. For hematology physicians, myeloma is a separate disease, but lymphoma, leukemia often overlap. I'll tell you, leukemia is a cancer which is in the blood.
Right.
Okay. Lymphoma is a cancer which is in the lymph node. And myeloma is a specific cancer of plasma cell which is present in the bone marrow. And the symptoms of myeloma are very specific. They causes anemia, hypercalcemia, fractures and renal failure. It's a very specific disease, it's a very specific symptom. But lymphoma, there are so many varieties of lymphoma. Leukemia, there are so many varieties of leukemia. And when you say leukemia, we are morely concerned about, acute leukemia.
Right.
The one which is more dangerous, more lethal, which requires more intensive chemotherapy, transplant often. Lymphoma, most often you do not need transplant upfront. And nowadays you have a whole gamut of targeted and novel treatments which are available, and we can treat the patients even without chemotherapy. So yes, lymphoma, you can say that more often than not, you get a patient who have lot of lymph nodes. Leukemia, where you have WBC counts are raised and you can see the tumor cells in the blood. And myeloma is a very specific disease of the bone marrow where plasma cells are affected.
Got it, sir. So now since you've talked about the variations in blood cancer, can you please tell us how do these variations affect the treatment decisions and outcomes?
Are you talking about the treatment outcomes of leukemia or lymphoma?
So both.
Okay, there are three variables in treatment of any blood cancer, and for that matter for any tumor. One is a host factor, one is a disease factor, and one are treatment factors. So what you are asking is only treatment factor. Please remember that the host factors and the disease factors are also important for the treatment outcomes. Now in 2026, we know the treatment factors have improved a lot. So now we have access to some molecules, some novel agents, some targeted treatments. So mostly, for example, in many cancers nowadays, we do not even use chemotherapy. We use targeted treatment. So we analyze by molecular method the targets available in a cancer cell and we treat those targets. And they're very effective, they're safe, and the side effect profile is very manageable.
Okay.
But at the same time, also we have to understand that the disease factor and the host factor haven't changed. Only the treatment factor have changed. So when you say that, earlier, 20 years ago, out of 100 patients of leukemia, all 100 or 20 patients only survived, 80 patients died, you can say. And now, out of 100 patients, I cannot claim that 100 patients have survived. I will say that, 40 patients have probably gone to a cure, another 40 patients have a prolongation of life, but 20 patients are still suffering and the 20 patients have still died. This is because the disease factors are also very important part of the treatment outcomes, and in a couple of patients where the disease factor is extremely poor, even modern treatments may not work. Okay, but it is important to identify the risk categorizations of the patients, and nowadays because we are treating the patients by disease risk categorizations, we are offering more holistic treatment to every patient, even those patients who are not gonna cured of the treatment, any treatment for that matter. But we are going to give you a holistic treatment, a treatment that is appropriate for them. Unlike in 20 years ago, where we give same treatment for everyone.
Absolutely.
And sometimes it may work and sometimes it may not. It doesn't work nowadays. We have a more accurate vision of what are we expecting from that particular patient. And hence, whenever you see the treatment outcomes have improved or not, you have to see a global view of the entire cohort and not from the very narrow viewpoint for one particular patient. Say you have seen a particular patient dying early and you cannot say that, the treatment has not improved. In hematological malignancies, everyone dies. You cannot say that. And somebody has survived. You cannot say, now it's improved and everyone is surviving. You cannot. You have to see the close view, and then you have to realize how the treatments have changed. Yes, it has gone better. Yes, it has become better. It's more targeted. It's more side effect free. But still there are areas of improvement. I think there are areas of improvement which is happening every year we are facing now, and there are some domains like complex cytogenetics, like TP53 mutated AML, which is still unresolved even today.
Yes. So, sirs, I think this is some big good news that we have, and also for our viewers, it's very reassuring. Now, sir, let's talk about fear versus reality of treatment.
Okay.
So, sir, when people hear blood cancer, the fear can be very strong. So, I just wanted to know, have the treatment outcomes now improved than what they were some years back?
Yeah, they have improved. More importantly, they have improved the diagnostic and the staging part also.
Okay.
So we now know which patients have a very good chance of cure, which patients have a moderate chance of cure, and which patients doesn't have actually any chance of cure. So rather than just hitting everyone with the same thing, we absolutely have a vision of which patient will do well, which patient will not do well, will need transplant, and then there are some very small category of patients, but unfortunately there are some patients who will not even do well with a transplant.
Absolutely, sir. I was just going to ask you that only, that there's a perception that the treatment will involve some aggressive approaches like transplant.
Yeah.
Is that always necessary, sir?
No, not at all. Nowadays we have so many different options of chemotherapy, immunotherapy, and I'm talking about in lymphoma, for example, most of the time we do not need a transplant. Upfront at least we do not need. We need a transplant in lymphoma who have relapsed.
Right, sir.
Multiple myeloma we need transplant, but they are autologous transplants. So these transplants are done from the patient's own cells. Acute leukemia is the segment. I mean that acute leukemia, myeloid leukemia or lymphoid leukemia, they are the segment of blood cancers who may need allogeneic bone marrow transplantations.
Okay.
And they are the most aggressive type where we might need both intensive chemotherapy as well as stem cell transplants upfront.
Thank you, sir. This is very insightful. So now, sir, since you talked about transplants, for someone who's hearing it for the first time, what exactly does bone marrow or a stem cell transplant mean?
Okay. It means transfusing stem cell in a patient.
Okay.
Okay. Now, the stem cell can be patient's own stem cell when it is known as autologous, or it can be somebody else's stem cells when it is called allogenic. Allogenic stem cells can be a matched sibling. I'm coming to matching when it is from a sister or brother, or it can be haplo when it is not matched, and it can be a matched unrelated donor, which is usually taken up from a registry. Okay, so there are three types of allogenic transplant and autologous transplant.
Right, sir.
In patients where bone marrow is not involved, okay, let's say you have lymphoma, okay, so let's say you have myeloma. So myeloma, the hematopoietic cells are not involved. It is a proliferation of plasma cell. Here we can use patient's own stem cells.
Okay.
Okay, but in patients where the bone marrow is involved, the hematopoietic cells are involved in cancer, as in acute leukemia, there we cannot use patient's own stem cells. Okay, we cannot use. So we have to use somebody else's stem cells. That is called allogenic stem cell transplant.
Okay, so I think so you have covered. I was just going to ask you what is matching and who can be the perfect donor.
So matching is required for all transplants, be the solid tumor. For example, in other solid transplants also matching is required. It is a tissue matching.
Okay.
So let's say I am giving a tissue, any tissue for example, to another person. That person's immune system is going to reject it, right? It is a foreign body. So to have a transplant successful, the immune system has to match, and this matching of immune system is called HLA, human leukocyte antigen. So there are two classes of human leukocyte antigen, class 1 and class 2. In total there are 12 alleles. So class 1 has 3 loci, class 2 has 3 loci. In total there are 6 loci. 6 plus 6 from both parents is 12. So 12 alleles. If you have 12 by 12 match, you have absolutely no chance of rejection.
Okay.
But if you have like 11 out of 12 alleles matched, 10 out of 12 matched, the more unmatched it is, there are more chance of rejection. Nowadays we do even haplo. Haplo is anything which is more than 6. Okay, 6 or 7 or 8. Even they are successful. It's not uncommon. So all over India and all over the world, people are successfully carrying out haplo-identical transplantations. More side effects, but it is also successful. But then it is more important to have matching, because matching reduces the cost of transplant. We need less supportive care, and we obviously have less amount of side effects. The side effect that we call graft versus host disease.
Right,
okay? So we have less amount of graft versus host disease. So if a patient has a full match donor, and mostly these full match donors are siblings.
Okay.
So if a person has like 3 siblings, there are higher chances of matches.
Okay.
If somebody has only 1 sibling, there is a less chance. So there is like 25% chance. Each one has 25% chance of full match sibling. So somebody has a 4 siblings, they have a higher chance of having a mass sibling donor rather than somebody who has only 1 sibling. Now since the family numbers are decreasing, we are getting less and less number of mass sibs.
So thank you so much, sir. This brings in a lot of clarity for our viewers as well. So another question that came in my mind is, sir, especially in the northeastern part of our country, what do you think, sir, are some of the unique challenges that comes along with the transplant? Like, is it with the donor thing, or is it the accessibility issue?
Actually, both. First of all, the transplant program itself started very late, okay, as compared to the rest of India. Here, the transplant program started in 2021. And till now, we have 3 transplant centers in Northeast India. So BBCI was the first, and then Guwahati Medical College opened up another center, and then there is another center in Imphal, who are currently doing autologous transplant. Now, the problem with, because we have less number of transplant centers and because the accessibility has been only recent, the doctors and the referral centers, the one who are actually, manning the primary health center or maybe community health center or maybe the civil hospitals or maybe the other hospitals across the different towns, they are not aware of it. As a result, they do not refer. Okay, so somebody is transplant eligible, somebody has an aggressive leukemia, they will say that transplant facilities are not available.
Absolutely.
And then they will refer the patients outside. So that is one problem, and people do not often have enough means to go to private places in Chennai or Bangalore and Delhi. That is extremely expensive. So that's one problem. The second problem is very unique to the Northeast, and it is related to the genetic makeup of Northeast. Okay, so as I said, nowadays the family numbers have reduced. So people have 2 children. Only rarely the people have, families have 3 children. So the chance of getting mass sibling donors are reducing. Okay?
Absolutely.
Now you have to rely on the registry. So there are 2 big registries in India. One is a Datri, which is based in Chennai, but then often operates from Mumbai, and then there is a DKMS, which is based in Bangalore.
Okay.
Now these registries are made by voluntary donors. Okay. So they go to places, and then they encourage people to enroll for stem cell donation. Okay. So they take a chick swab or sometimes a blood sample and they run the HLA, and in that way they make a directory of HLA subtypes of every donor who are eligible and who are willing to donate. Now, if you have a patient, then they will run the HLA haplotype and check whether the HLA haplotype matches with one of the donors, and then they will engage the donors to have a donation and then do a transplant. Unfortunately, there are very few representations from Northeast India because people are not aware of stem cell donation. People do not know that stem cell donation is one thing, right? And so important thing. So, and our genetic makeup is very unique.
Yes.
Northeast, because there are so conserved tribal communities in Northeast India, they do not share their genetic makeup with the rest of the mainland India.
Very true.
Now, if somebody has a national registry, has so many different donors from Maharashtra or from Delhi, from North India or from South India or from West India, even from East India, they do not have the representation from the tribal communities of the Northeast India. So we do not probably have sufficient representations from each of the tribes, like say Karbi or Boro or Khasi or Naga communities. We do not have sufficient representation. As a result, if any one of these patients are affected and unfortunately they do not have a mass sibling, we are left with no one. We do not have a mass sibling. Now the need of the hour is to have a robust awareness system to drive a stem cell donation in the northeastern community. Each conserved communities, you cannot have a stem cell drive across Northeast India and only collect, some community. You have to have enough representation from each of the communities. There are more than 200 communities, conserved communities in Northeast India. You have to collect enough representation from each. Then only there will be a day when our children, when they are affected with leukemia, they have an equal chance of survival as any children of India. So you can understand a patient of a children of Punjab or a children of Maharashtra or Mumbai when they are affected by leukemia, they have an easy chance of survival, right?
Absolutely.
A child from Nagaland or Meghalaya, they do not have that chance of survival.
They don't. Absolutely.
Because we do not have a matched unrelated donor. So this is one area where government will be able to, intervene.
By increasing the awareness programs?
Number one. And number two, to actually initiate a stem cell, because it is an expensive thing.
Right, sir.
You have to collect the voluntary donor. You have to first do the awareness. Then you have to have a setup where people can actually come, get their test done, cheek swabs done. Registry has to be maintained. Initially, for 10,000, 100,000, you will not have any meaningful response.
That's right.
You will only have a meaningful response after, let's say, 10 lakh people are volunteer. Then only you will have a registry where you can have matches. So till then, it is going to be expensive. It is not possible for an NGO or for somebody like a small organizations to run it to that extent where you can have 10 lakh voluntary donors, and then you can have outcomes, right? From their voluntary donors, you will have a match, and then you will do a transplant. Only then it will come back. Otherwise, it is only going to be, expense.
Absolutely.
So government has to, also deal with
take this initiative mainly. So we're looking forward to this solution very honestly.
I have been working, so we did a matched unrelated donor transplant last year. That was the first. I'll tell you the struggle that I went through.
Yes, sir.
So when we did a unrelated donor transplant, fortunately, it was the 6th time. We did 5 times we run a matched unrelated donor registry. 5 times it came out negative for the reason I explained to you.
Yes, sir.
But the 6th time it came out positive, the 10 out of 10 match. And we asked the doctor to provide us with the stem cells, and they provided us. The donor was from some place in Punjab. And the problem, there are some more challenges, that our airport is also not aware of such thing.
Yeah, that's a thing.
So the stem cells will come, it cannot be screened, it cannot be x-rayed. You have to notify the airport that such a product is going to come, and
they're not briefed about it.
They are not briefed about it, and they do not know about it.
Exactly.
So initially, I had a difficulty convincing these guys.
Absolutely.
That you see, this is a and this is a norm across India. This is happening.
Yeah.
And Datri is a very legitimate organization. And then they agreed. You just imagine the level of awareness.
Absolutely.
And from where you will have to start.
No, sir, that's great to know, and I think it's reassuring for our patients as well to know that awareness programs like this are being held in this region of the country. Talking about transplants, many patients think that transplants are very risky and are the absolute last option. How true is that?
No, they are not last options. Nowadays, they are frequently accepted as a curative, very safe curative approach. In fact, if you look at the risk element, autologous transplant has less than 5% mortality.
Okay.
So during transplant, we don't see losses in autologous transplant. So patients who have myeloma or lymphoma where autologous transplants are done, you can safely say that they're very safe treatment approaches. Allogenic transplant, the risk really depends upon what kind of matching that we are having. So if you have a mass sibling donor transplants, you again expect not more than 10 to 15% transplant related mortality. In haplotransplant, you will have a slightly more than 10 to 15%. But again, looking at the bigger picture, you can see that 75 to 80% patients across all cohorts, across haplo and ethnical or allogenic or autologous, will have a safe journey through the transplants. They will not have a TRM, transplant related mortality. Now, there still can be mortality because of non-transplant issues. Most of the non-transplant issues are usually relapses. But if you don't do a transplant, then the relapse are going to be even higher.
Right, sir.
So if you have, let's say, if you have done 10 transplants and 1 patient died of TRM, you have 9 patients, and out of 9, 2 patients relapsed. You said that 7 patients have survived, are cured. If you do not do a transplant, then you are going to lose more than 3. You are going to lose 4 or 5 patients, because most of the patients will have a higher number of relapses because you have not undergone a transplant. And because you have done a transplant, only 2 out of 9 patients have relapsed. So this is a very simple math that I'm going to show you. That's why nowadays transplant are said to be a feasible, safe and curative approach upfront. It is not like the last resort. No, it's not last resort. It is the upfront approach in most situations. Like in myeloma, in acute leukemia, it is the first approach. Sometimes in lymphoma and in other diseases where we do transplant in relapsed refractory, then it is last resort. But even then, it is safer than most people assume. People assume transplant has to be a very, highly intensive, very aggressive approach.
Yeah.
Yes, it is an intensive approach. Yes, you need to be in a very confined settings, in a HEPA filtered unit for 30-40 days. But that doesn't mean you are going to come out more often than not.
Thanks for clearing that, sir. I think this is a misconception that most of our viewers
Yes.
had. Also, sir, after having undergone transplant, are patients able to carry on with their daily life?
It depends upon how long are we going to have them confined. So we have some restrictions. For autologous transplant, that restriction is 6 months. After 6 months, they are usually free to work, continue their normal life. For allogeneic transplant, it is usually 1 year.
Okay.
If the patient has GVHD, graft versus host disease, then this rest period increases.
Okay.
And the reason is this 6 months and 1 year timelines are because at 6 months of time after an autologous transplant, we vaccinate the patients.
Okay.
So when we do a conditioning treatment for transplants, we abolish the patient's immune system. We have to vaccinate them again, okay, so that they become eligible to go into the public. Remember, because there are a lot of infective organisms out there.
Absolutely, sir.
And we are immune. But the patients are not immune because we have killed the patient's immune system.
Right, sir.
During the transplant. So we have to vaccinate them. That is done at 6 months' time in autologous. And for allogenic, that is mostly done in 1 year time, depending upon whether they have GVH or not. If they have GVH, then we have to prolong. We have to go beyond and give it at 18 months or 2 years' time, whenever the patient is safe enough to be vaccinated. And then they can go on carrying normal life.
Right, sir. So that makes a lot of sense. Lastly, what I wanted to ask you is, for patients who are avoiding persistent symptoms, what advice do you have for them?
Do a CBC. If you see that I do not know what is happening, but I am having fatigue, okay, it may be completely a normal thing to have. It can be the patient has a viral infection. Sometimes hypothyroidism can be reason. Sometimes even the patient's uncontrolled blood pressure or sugar can be because of one of the reason. But the point is that CBC is the last thing that people do. People do not do that. I urge public that whenever they have like a fatigue, they are not feeling well, they have like this fever coming and going, and they have like bleeding spots. Now, bleeding spots are like a red sign, okay, red flag signs. Somebody has bleeding spots, they have to absolutely do a CBC, complete blood count. Now, CBC does not mean bloodary. Complete blood count, CBC, okay? If you do a CBC, you can do that in any hospital any diagnostic center, nearby labs. That will give you information, and in most of the blood cancers you will get information in the CBC itself.
Okay, thank you so much. That's really insightful. So I think one takeaway from today's conversation is that just because something is not visible, it shouldn't be ignored. And also, diagnosis is not the end, and treatment approaches have become a lot more advanced and hopeful than they were a few years back. Thank you for tuning in. Looking forward to more such podcasts in the near future.